Okay, let's get started. My great pleasure to introduce today's speaker, Nate Clendenin. He's a young physician scientist in our department. He's currently an assistant professor of anesthesiology, and his research interest is in perioperative coagulation and organ protection. He's has an outstanding CV. I was very impressed reading it this morning. He studied molecular biology at the University of Colorado in Boulder before he went to obtain his master's degree in neuroscience at the University in New York. After that, he went to Dublin in Ireland to study medicine at the Royal College of Surgeons, where he graduated with honors. After that, he went on to Yale University to complete his residency training, where he also was selected as a research scholar. So he was highly active in research, and finally came to Denver, where he actually was the first to complete a fellowship in a combined fellowship program in research in cardiothoracic anesthesiology. Today he's going to present some new data in the field of anesthesiology and how all of us could get more involved in basic science and or translational research regarding anesthesiology. My great pleasure. Thanks a lot, Nate. Why are you using it?
Okay. Well, good morning. Thank you very much for that introduction. The title of my talk is Anesthesiology Research in 2018, a review of notable accomplishments and future opportunities. So, learning objectives for today is to review the most significant research findings in anesthesiology for the year, understand some of the updates to current evidence-based guidelines in anesthesiology and clinical practice, and learn about some of the ongoing research efforts within the University of Colorado Department of Anesthesiology and opportunities there are for getting involved in some of that research. So disclosures, I have no conflicts of interest pertaining to this presentation. So when I was looking at 2018, I wanted to put it in some sort of context of what anesthesiology research has been, so I went back as far as I could. The Wood Library Museum has a really interesting interactive timeline, and I drew from that. And what I realized is a lot of these accomplishments in anesthesiology were related to our tools, specifically to pharmacology. So sort of the first instance of pharmacology that could be part of our specialty that we might recognize today is 4000 BCE. There are mentions of opium and using this for analgesia. And then sort of progress was slow. The first set of the pharmaceuticals were sort of plant-based analgesics or anesthetics. So henbane shows up in 2250 BCE. First use of cannabis vapors for analgesia was 600 BCE. The ancient Romans were using mandrake boiled in wine for anesthesia and procedural sedation. And then in South America, coca leaves and cocaine were used to provide some sort of local anesthesia for wounds, for providing procedures. Again, another big gap, but in 1775 was the first description of oxygen and nitrous oxide. And then it was almost another 100 years before the first presentation of ether for procedural sedation for dental extraction. And the basis for that was ether used to be almost like a party drug for these ether frolics, and then it ended up being applied for medicine later. Neuraxial anesthesia was introduced in 1898 and followed shortly thereafter by epidural anesthesia. The next sort of IV intravenous anesthetics were introduced in 1934 with thiopental, and then there was sort of a rapid production of new medications. So etomidate and ketamine are actually twins. They came out in 1964, and followed by some of the more modern anesthetics that you would recognize today with isoflurane in 1974, propofol in 77, Desflurane 92, and then Sevo 94, and dexmedetomidine in 1999. So along with all these pharmacological tools, the practice of anesthesiology sort of expanded with what we were able to do. So pulse oximetry was developed in the 1970s, and this was a massive leap forward in patient safety. Prior to that, anesthesiology was one of the higher risk specialties from a medical legal standpoint. And after the advent of pulse oximetry and focus on patient safety, it's now one of the least litigious because we are able to keep our patients so safe. So within this context, I tried to place some of the accomplishments of the year. So I'll go through the methods of how I decided. I almost certainly missed quite a bit of notable accomplishments, but these represent a range from sort of established practices that we're probably going to do today, but there's new evidence supporting their use, to sort of novel breakthroughs that have a great potential to continue that 6,000-year timeline of new tools that can sort of expand what we do. So I went through and also reviewed some of the available guideline updates. I took all the abstracts from anesthesiology and analyzed them for word frequency to try and see if I could detect a trend with what's going on in research, so it wasn't just subjective. Reviewed the literature, and then also considered some other research that may have implications for our specialty that's worth knowing about. And then hopefully can apply these to perioperative medicine. So new medications for 2018, there were between 30 and 40 new FDA-approved medications, two of which I thought may have direct implications, and you may see them. The first one is lofexidine. So this is an alpha-2 agonist that's orally available, and it was approved for reducing symptoms of opioid withdrawal. So this is the sort of main largest trial that sort of led to its approval. It's a phase 3 randomized multi-center double-blind trial. So this is inpatient opioid withdrawal. And so their primary outcome for this was a standardized questionnaire of opioid withdrawal symptoms. And this was their main finding, so that their primary outcome was for day 3, reducing the self-reported withdrawal symptoms that the patients experienced, and they had a significant reduction in those. And they also measured catecholamine release, which is thought to be the mechanism of lofexidine. So it's able, through its alpha-2 mechanism, it's able to reduce some of these withdrawal symptoms. And the reason this medication is important is this is the first non-opioid approved medication for withdrawal symptoms. So next medication that I'm pretty excited about, this was approved at the end of 2017. I'm not sure if we have it on formulary here yet, but this is angiotensin II for the treatment of vasodilatory shock. It's been quite a few years since we got a new presser, and that's very near and dear to my heart because probably very few days go by where I'm not engaging one of these medications. But this was sort of the largest trial of angiotensin, and the primary outcome for this was the ability of the medication to increase the mean arterial pressure. And this was an incredibly enriched population, because in order to be included in the study, you had to be on 0.2 micrograms per kilo per minute of norepinephrine or the equivalent, and then you were randomized to either placebo or angiotensin II. So this is the main figure from that. Angiotensin II is in blue in the top line. So even in these patients who were in extreme vasodilatory shock, angiotensin II was able to augment the mean arterial pressure above norepinephrine or whatever other pressors they were on. The caveat for that, this was an incredibly high-risk patient population. The mortality was between 25 and 35% in the study for both groups. There's no difference in mortality for that, but angiotensin II there was a signal showing that thromboembolic complications may be more frequent. So whether that's a side effect or it may be beneficial in hemorrhagic shock, so the post-marketing surveillance of this drug will have to reveal some of that. But new presser for 2018. So there was one clinical guideline update put out by the ASA, and it's the practice guidelines for moderate procedural sedation and analgesia in 2018. A lot of that remains the same. So the evidence in this area is limited because trials of moderate sedation and sort of guiding how we should monitor that and what the standards are the guidelines are based mostly on expert opinion. But the take-home points from that is that continuous capnography is now recommended for the moderate procedural sedation. And they've now classified the medications into the intent. So the big split is between medications that are intended for general anesthesia. So this includes propofol, etomidate, and ketamine. So if you're going to be providing moderate sedation with medications that can provide general anesthesia, it's expected that the provider is able to provide general anesthesia level monitoring and care. And this is contrasted with midazolam and the benzodiazepine class, ketamine, and dexmedetomidine, which does not have the same monitoring requirements. So those are the main guideline updates. So taking all of the abstracts from anesthesiology and just putting it into a word count, this is a word cloud. So the larger the font on the word, it corresponds to how often it was mentioned in the abstracts of the anesthesiology journal for 2018. And what I found really encouraging is that by far and away, patients came out on top in the center. So I think it reflects that anesthesiology is very much patient-focused. And as a specialty, we're very focused on individualizing treatment for each patient. So there are protocols that generally work for most people, but every day, every patient, it's being customized to their own physiology and their response. And I was a little surprised surgery was just a little bit larger than anesthesia on this. But other notable words that came out of this were opioid and pain, postoperative, sort of the focus of what's been going on in 2018. So building on that, the opioid epidemic sort of touches everything we do. We see patients who are either on chronic opioids for pain or the sort of downstream effects of this. So the transplant is up quite a bit when, and it's coupled to this, the incredible mortality associated. So it's been called a modern day plague, just given by the numbers of people affected. So just looking at the map, the age-adjusted death rates are incredibly high, and Colorado's included among those. And just looking at the opioid epidemic, it's risen alongside the prescription opioids. So it's been described to be in three waves. With the first is sort of prescription opioid overdose deaths was sort of the first wave, and that corresponded with liberalization of using these medications for therapeutic purposes and then getting either diverted or acute use turning into chronic long-term use. This was followed by heroin, and then this third wave that we're experiencing now where there's more synthetic opioids that are being used as substitutes once the supply and the availability of prescription opioids has been limited further. So this is in this segue into an important study showing the benefits of preventing acute pain in order to prevent long-term pain, to sort of mitigate some of the effects of that, of the opioid prescriptions. So multimodal pain management strategies have been increasingly used over the past several years. But I wanted to present this paper. So this is the Association of Multimodal Pain Management Strategies with Perioperative Outcomes and Resource Utilization. So this gets at primary prevention of opioid abuse. So this was a population-based study. And they had 1.5 million patients included in here. And they stratified them into patients undergoing total hip and knee arthroplasty. And they compared groups that had either opioid-only acute pain management versus additive multimodal techniques. So whether that's a peripheral nerve block, the NSAIDs, COX-2 inhibitors, and they stratified them by opioids versus number of these additional additive techniques. And so what they found is that with each additional approach to providing analgesia, you were able to reduce the prescription medications for opioids that were required for acute pain management. So this is an effective technique. There are smaller studies, but looking at real-world use, I think this research study is important because it shows that even on a population level, you can see a clear signal that it's beneficial. And most of the effect is driven by NSAIDs and COX-2 inhibitors. So along with the opioid epidemic, a big part of the problem is that along with analgesia, you get all these side effects that we're well aware of, mostly the respiratory depression. So you develop tolerance and dependence, and then while you develop tolerance to the analgesia and also the dosing, you don't necessarily develop the same level of tolerance to the side effects. So looking back at the opium plant, so it's sort of a mix of a lot of different opioids. And all these different effects are not just mediated by sort of the classic subtypes. So typically it's thought of as mu, kappa, and delta opioid receptors, but recent research in the past couple of years has identified 19 different versions in humans. So there's a whole mix of splice variants, and every person has a different quantity of these receptors, and so they'll both have a different tolerance and a different effect. So this is the physiological basis of opioid rotation. So fentanyl is not the same as hydromorphone versus morphine. They all have, and methadone as well. It's not just the other off-side effects, it's also that the opioid receptors themselves are different. So up here in the red box, these are all the different splice variants. So there's the different genes, and they can be mixed and combined in quite a few different ways to get all those subtypes that I talked about. And classically what's been studied is this 7 transmembrane domain. So it's a G protein coupled receptor. Almost about 40% of all the medications we use target a receptor like this, and opioids are like that. But looking at an ideal opioid, you'd be able to isolate these effects. So if you could have analgesia without the side effects that lead to sort of the opioid epidemic and everything else that's sort of detracts from their therapeutic use and increases the risk, the ideal analgesic would have just the pain-relieving properties without the respiratory depression, reward behavior, or physical dependence. So a group out of Sloan Kettering has been working on this a few years, and they've made a pretty notable breakthrough this year, and I want to present that. So not only do you have these 7 transmembrane opioid receptors, there's also a 6 transmembrane version and splice variant that's present in humans, and they have developed a specific agonist for this truncated receptor. So it was designed out of naltrexone, and it's called IBN-TXA. And what they've done is shown that by targeting the 6 transmembrane receptor variant of the opioid receptor, they're able to isolate analgesia from the side effect profile. So this was a paper in Anesthesia and Analgesia demonstrating that. So what they did is they took a double knockout mouse. So they had no opioid receptors, and they did not respond to either morphine, methadone, fentanyl, any of the classic mu opioid receptors. And then they knocked back in with a viral vector, and just putting the 6 transmembrane version of that opioid receptor And they were able to demonstrate that they could rescue the analgesic effects of IBN-TXA without rescuing morphine or fentanyl. So the reason this is notable, and I know it's early since this is in an animal model, but what they've demonstrated is that it is possible to take a medication that only has analgesic properties without some of the side effects. And the fact that it's an naltrexone derivative, which is used in humans, increases the likelihood that this will be translatable to clinical practice. But by demonstrating that control, it increases the likelihood of success. So another big topic that I think sort of captures a goal of anesthesiology in general is trying to protect organs. Anesthesia, as it's practiced, is incredibly reproducible and incredibly safe. And what that's led to is sort of an expansion of how sick patients are that we can take care of, and that the intra-op mortality is incredibly low. So now that has improved considerably with monitoring, with best practices, with new medications, the next step is zooming out a bit and looking at how perioperative decisions influence longer-term outcomes. And what that's led to is really focusing on organ protection, because some of these injuries that are sustained in the operating room are not apparent for weeks or months afterwards. So there's a big push to look and see what can be organ protective to help the long-term outcomes beyond just getting someone through the OR. So one of the most effective medications that we already have, we're already using, that has a very clear signal is dexmedetomidine and morbidity and mortality. So this is a meta-analysis looking at randomized controlled trials of dexmedetomidine and looking at its effect on post-operative mortality and morbidity. So this is 31 randomized controlled trials. It included over 9,000 patients. And the outcomes that they looked at and they were able to combine for quantitative analysis was 30-day mortality, length of mechanical ventilation, length of stay, and delirium. So the main finding of this is in the forest plot. So at the bottom, going more towards the left, it's favoring dexmedetomidine for 30-day mortality. And towards the right would show that it didn't have an effect, and it's clearly within the margin of providing benefit. And the only caveat to this is dexmedetomidine has mostly been studied in cardiac surgery. So when you look at the subgroup analysis, among that 9,000, only about 1,800 is in non-cardiac surgery. So the signal is not as clear there, but when combined together, it seems that dexmedetomidine is able to provide a mortality benefit through an unknown mechanism. So looking at another approach to organ protection, so dexmedetomidine is something that we can do safely. It's common, and it seems to provide benefit through an unknown mechanism. On the other side, there's an experimental clinical technique called remote ischemic preconditioning. So this has gotten an enormous amount of interest. There's over 190 clinical trials applying this. And the reason for that is it's such a low barrier to entry. So all remote ischemic preconditioning is putting a blood pressure cuff up above your systolic pressure to occlude blood flow to the arm. You leave it up for 5 minutes, and then you let it down, and you repeat this cycle 4 times. So incredibly low cost, available, and incredibly low risk as well. And the way this is thought to work is the ischemic arm produces a signal that tells the rest of the body that ischemia is possible, and the idea is that this reduces organ injury if there's a subsequent ischemic insult. So this got a lot of attention last year because there were 2 multi-site prospective trials in 2 different countries in cardiac surgery that showed that it was not effective. And one of the big problems with this is that they found out after they did these multi-million-dollar trials is that propofol interferes with the effect. So there's a big discrepancy in studies that used remote ischemic preconditioning when patients are receiving full anesthesia, since propofol is sort of the most common agent used. So the thought is that it blocked the effect. The cardiologists who are using the more procedural sedation with midazolam and fentanyl, they're showing really impressive results with it in the cath lab, with numbers needed to treat of 9 to 20. So now researchers are starting to come back and with that new information and look at it in more detail. So this is one of the follow-up studies after those major clinical trials failed, but it was done by the cardiologists. And what they did was it's a randomized controlled trial of remote ischemic preconditioning. And they took over 500 patients who presented with a STEMI to the cath lab, so they're going to have revascularization therapy, and then they randomize them to either get this remote ischemic conditioning or the usual care, which is the cath lab intervention. So they followed these patients up for 3 years, and they found that they were able to reduce mortality and heart failure after STEMI with echocardiography. So some of the advantages of their study design over the cardiac surgery study design is they already had patients who have massive organ injury. They're in with complete ischemia of their heart with the STEMI, and then they revascularize. So there's this reperfusion injury component as well. And so before they're revascularizing, if they're just putting the blood pressure cuff up, they're able to give these impressive results that even going out to 3 years, mortality's lower. So in summary, with remote ischemic preconditioning, there is a signal that it can have significant benefits, but because ischemia and ischemic signaling is so fundamental, there are quite a few caveats as far as when it's going to work, who it's going to work for, and which situation. So with the 190 ongoing clinical trials, pretty much every combination of patient and procedure is being tested at the moment. So as this body of work sort of becomes published and becomes available, I think we'll have a clearer sense of how this low-cost, low-risk intervention can be beneficial, since it's using available tools we already have. So another notable shift that I think is important for the specialty is emergence has been treated as a passive phenomenon. So we induce general anesthesia, and then by withdrawing the medications and waiting, or providing stimulation like suctioning, or using sympathetic outflow to sort of pull someone out of anesthesia or hasten that, there's this new shift to trying to look at emergence as a active phenomenon and something that you can target and use as an endpoint. So just as an analogy, neuromuscular blockade has a long history of being able to induce it and then reverse it. Do we need to run, or is it okay? Amber, okay. So I feel like this is an important paradigm shift, and one that is going to be important. And this is sort of an early clinical trial. There is an ongoing clinical trial of methylphenidate for targeting emergence, but this one was completed and published this year. And as a surprise to no one, probably caffeine promotes waking up, I suppose. But it was a randomized double-blind crossover study. So it is small. It's 8 healthy volunteers, but the crossover design greatly increases the power. What that tells you is having an N that low and still being able to see an effect is that it's pretty pronounced. So they took healthy volunteers, and they had them under 1 hour of isoflurane anesthesia. And then when they turned 10 minutes prior to stopping the anesthetic, they either had a saline infusion or a caffeine infusion. And what they were able to show is that with the caffeine infusion, the emergence time was halved. So they're able to effectively target that and hasten emergence. So coupling an emergent medication with a shorter acting agent could potentially turn emergence into an active phenomenon that's controllable instead of passive. So another big breakthrough, and we went over one of these papers I'm going to talk about in Journal Club because it was so, it's a novel tool, and it's looking at how to predict what patients will do, so their outcomes. And there's been a lot of success with this with search algorithms. So Google, and specifically, has for several years been able to predict what you're going to type in or what websites are relevant. And one of the ways they've been able to do that is with these deep learning artificial neural networks. And so what this is you take a large set of data, and it has to be classified, so you know what the outcome is. So one of the examples is they were able to have an algorithm that could predict whether a picture is of a cat. So they fed it a whole bunch of data saying this is a cat, this is not a cat, but they did not provide any rules as to how to predict. And through using multiple iterations with the training set, an artificial neural network is very adept at classifying these sort of 0-1 outcomes. So this year, there are multiple publications looking at using deep learning to predict patient outcomes. So originally developed for sort of internet search, and it's now being applied to medicine. So they took almost 60,000 patient records, and this was low risk from an outpatient surgery center type setting. And they divided this into about 40,000 for the training set where they knew what happened to the patients, and then they validated it on a test set. And the way they developed this neural network is they picked about 70 or 80 features they thought would be important for mortality, and then fed that into the system. And this is what it looks like over on the left. On the far right, you take your outcome, and in this instance, it's mortality. So 0-1, who lives, who dies. Then on the left-hand side, they put in all the factors that they thought might be predictive. And from there, you set up the computer algorithm to have multiple layers of taking the input and breaking it down into different pieces and fitting the model until it's able to predict the outcome on the right. So this is an expansion of logistic regression where you put a few factors in and then try and predict from there. But the difference is this is unsupervised. So the computer runs through its algorithm trying different things within certain parameters, such that you get a penalty for making a mistake, and the best model wins at the end. So you hold back some of the data, and then you see how it does on real-world data. And that's what they did. The advantage of this procedure is you don't need to know what has to go into the model. But the problem with that is you also don't know how it's working. You may be able to build a tool that can predict mortality, as they did in this group, but you won't be able to say what's important. So these are the ROC curves. So the rate of true and false positive tests with different prediction algorithms. So pretty impressive is just the simple ASA score that was developed a number of years ago, has a pretty impressive area under the curve of 0.84. That's been criticized for requiring some level of judgment and training to see a large amount of patients and sort of be able to correctly classify them into the ASA physical status, but it still performs pretty well. This particular artificial neural network, if you look at the bottom, it's in the light blue, including the ASA score, and the artificial neural network was able to get an area under the curve of 0.91. So that's 91% of the tests that were included were able to correctly predict mortality. So in summary, the deep learning works pretty impressively well, especially because this is a really early proof of concept. So most typical artificial neural networks doing this have millions, tens of millions, hundreds of millions of variables, and this was able to get a reasonable result with just 60,000. So as the electronic medical record is put together and these models are built, they will continue to get better. And this is proliferating. So in this same issue, there were 3 other applications of this technology, and that's to predict hypotension, to predict the bispectral index, and also looking at the arterial waveform. So depending on what data you feed into it, this is a very versatile tool for diagnosis and prediction. How that will be implemented practically remains to be seen, but it's been incredibly effective in other disciplines, and it is coming to anesthesiology. In fact, it's already here. It's being built. Okay, so another one is kind of surprising. I was very skeptical about xenotransplantation, as you probably are at the moment. So let me explain what it is. So it's taking organs from an animal and then being able to use that for cross-species transplantation. There's been work on this for at least 30 or 40 years, and it has been tried in humans to disastrous results. But there's been a major breakthrough this year and last year, making this closer to practical clinical trials. One of which was incredibly precise genome editing with CRISPR-Cas9. This made news in the past couple of weeks because a researcher in China used this gene editing technology in a human and has claimed that they were able to edit out the CCR5 receptor, which is the receptor that HIV uses to infect cells. So it has been applied in mammalian systems, and the reason that's important for xenotransplantation, there are a few major barriers to being able to use another species organ. As you're probably aware, organ rejection is a major problem. But also, animals have different viruses. So there's a particular set of endoviruses in pigs that the scientific community has said you can't do xenotransplantation until you solve this problem because, as evidenced by some of the influenza outbreaks, this cross-species transfer of infectious agents could be disastrous. So that was a major hurdle that had to be overcome. And using this gene editing technology of CRISPR-Cas9, they were able to selectively cut out all this pig-specific endoviruses, thereby clearing that hurdle. The second breakthrough that just came out this year is that by modifying the organ protection strategy, they were able to clear the function hurdle and the time hurdle of how long a cardiac transplantation would last in a pig to baboon model. So pigs have approximately the same size organs, and baboons are reasonable surrogates for humans. And the way they accomplish this is the main immunogenic feature on that our body recognizes as being foreign is a sugar called alpha-gal. So a genetically engineered pig without alpha-gal has been made, and then they also modified the organ rejection procedure. So incredibly impressive results is that it took 3 tries with these small cohorts, but they were able to get 5 baboons to survive well past 6 months with this new protocol, and that clears the criteria where 60% of the xenotransplanted organs in a model system would need to survive for 6 months. And that's the international community has shown that this is the threshold where human trials could start with this technology. So it is potentially possible that organ transplantation will become an elective daytime procedure, which I'm quite excited about that prospect. So I want to transition into some of the clinical research at the University of Colorado that's ongoing, and tools that are available that make it easier to get involved than it has been in the past, one of which is pretty unique here at the University of Colorado, and it's called the Health Data Compass. And this is a large initiative by the School of Medicine whereby they are building, they have it built that it's a copy of Epic going back to 2011. And all the clinical data is stored there. And they have a team of full-time analysts that will be able to pull this data for you and deliver it. And this is provided free of charge to university faculty. So it's incredibly powerful. So just as an example, a recent finding was that half of your platelets are made in the lungs. And this was shown in mice, and this is sort of a novel finding. So I wanted to look at how clinical variables of lung function might be associated with platelet count to see if there might be a signal there. So I put in a data request with Compass. I set very inclusive criteria. So I said everyone with a PA catheter, which I identified by patients who had a pulmonary artery pressure measurement. And then I gave them a list of 800 or 900 variables to pull along with that. So the total group was 3,600 patients. And then I excluded people who received a platelet transfusion to avoid that confounding factor. Just ask a simple question. If you have pulmonary hypertension, if your lungs are functioning differently, does it affect your platelet count? So very quickly I was able to find two things, one of which is that if you have, among the patients who lived versus died, unsurprisingly, patients with pulmonary hypertension had a higher mortality. It was pretty impressive. If you have a mean PA pressure above 25 millimeters of mercury, which is the cutoff for pulmonary hypertension, and you're at the University of Colorado, your mortality is 18%, going back to 2011. And then if you don't have pulmonary hypertension, it's 4.3. So it was very easy to check with this data. But then getting back to my question, I was able to detect a signal that you do have a significantly higher platelet count if you have pulmonary hypertension compared to those who don't. So already there, and this is in 1,900 patients. So this is just an example of sort of one question that I could answer very quickly without having to go and review 1,900 charts and pull that out. So it's an incredibly valuable resource, and it's a great place to start to test hypotheses in retrospective data before moving on to more focused studies. So another effort that I've been involved in is the anesthesiology biobanking, which is a human biologics cooperative. The idea behind this is to lower the barrier to entry as well by having a bank of existing samples. And the purpose of this is to generate preliminary data for grants and publications, because typically you come up with a question and then you go and get your IRB approval, targeting specific patients, and then having to go and collect those samples. Part of the idea behind this is that there would be already a number of samples available that you could apply to use to generate some preliminary data such that you can go and find funding to do the larger study. So the idea is that this could shave 1 to 2 years off of time from having a question, seeing if there's some signal that's actionable, and then going there. So it is a limited resource, so we're trying to be very judicious with it, but it's also incredibly powerful. And the big difference with our biobank compared to other biobank initiatives is we have samples before and after surgery. So what that can do is you can ask a question of what does different interventions do, or what does perioperative medicine do to something you can measure, which is pretty unique. Most biobanks only have a single time point by a lot of people. But as I showed with the caffeine study, you can get incredible power by comparing changes within one person, because you can take out some of that inter-individual variability. So we've been collecting samples since February, and just HBC dedicated samples, we have over 1,100 already. And the breakdown is here in this pie chart. They're mostly cardiac at the moment, but we also have a pretty good selection of other samples. So that's going on. And I've been able to use this to generate preliminary data, and it's It's incredibly flexible because you already have existing samples. If the research question changes, you can ask it in a different patient population. So in summary, anesthesiology has an incredibly long history of research and innovation going back 6,000 years, even before it was called that, and it was quite crude with sort of plant-based medications. Perioperative care does have major influences on long-term outcomes. Simple things we can do in the OR are able to reduce mortality at 30 days, improve cardiac function with an MI. There's enormous opportunity to expand beyond just keeping people safe in the OR to having long-term outcomes. And then 2018 was notable for pretty impressive breakthroughs in analgesia, organ protection, technology, and xenotransplantation that I think are an inflection point in these particular fields. But there's an enormous amount of exciting research built on previous inflection points that I couldn't include today, and you've probably heard of and maybe are already using. But I expect these to be more salient as they're established. And it's an exciting time to be involved in anesthesiology and anesthesiology research. Thank you very much. So one question I have is, does anyone have a breakthrough that they felt like was just this glaring oversight? What's missing? Yeah. Well, thank you.